If you pass a standard cardiac stress test with flying colors on a Tuesday, you can actually still drop dead of a massive heart attack on a Wednesday.
Yeah, which is a truly terrifying reality for a lot of people.
Right. And the reason is because everything we intuitively believe about how heart attacks happen is just, well, it's fundamentally wrong.
Completely wrong, yeah. We have this pervasive idea that it's just a mechanical issue.
Exactly. Specifically that idea that our arteries slowly clog up over decades, like old metal pipes under a kitchen sink.
Right, the classic plumbing analogy.
Yeah, and that is exactly our mission for this deep dive. Today, we are unpacking a really fascinating stack of medical history, autopsy reports, and clinical trials to decode a process called atherosclerosis.
Which is the exact mechanism that narrows and hardens your arteries.
Yes, and to set the stakes for you right at the top of this, you really need to care about this because this process is the engine behind most heart attacks and strokes. It takes more lives globally than all cancers combined.
It is the ultimate stealthy killer. And it's precisely because it operates entirely differently than we assume. We are dealing with an active, highly volatile biological process here, not a plumbing issue.
Unlearning that pipe analogy is the absolute first step today. We're also going to explore why ancient pre-industrial mummies actually had plaque in their arteries.
Which is just wild to think about.
It really is, and we'll dig into the counterintuitive reality of why the most narrowed, severely clogged artery is actually not always the deadliest one.
To get there, we really have to completely shift how we view the human immune system and its relationship with our blood vessels.
For sure. But before we get into how these plaques actually build up, going through the sources, there's an immediate point of confusion I want to clear up.
Okay, what's that?
The terminology. You hear the word arteriosclerosis with an R and then atherosclerosis with a TH. Clinically, how much does that one-letter difference actually matter?
Oh, it matters a lot. It basically dictates whether we're talking about a relatively harmless symptom of aging or a lethal disease.
Wait, really? Just from one letter?
Yeah. So arteriosclerosis with an R, that is the broad umbrella term, it simply means any hardening or thickening of the artery walls, regardless of the cause.
So it's just the overarching category.
Exactly. Under that umbrella, you have three distinct processes. First, you have Munkeberg sclerosis, which is essentially calcium depositing in the muscular middle layer of the arteries.
Okay, calcium in the muscle layer.
Right. You see it frequently in the elderly or in diabetics. The vessels get stiff, like rigid tubes, but the actual channel where the blood flows stays completely open.
Got it. So it's not blocking the flow.
No. Then you have arteriolosclerosis, which is the thickening of the tiny blood vessels, usually as an adaptive response to high blood pressure.
Okay, so neither of those are the processes producing those sudden, massive heart attacks we're talking about.
No, they aren't. The third process under that umbrella is atherosclerosis, with a TH.
Atherosclerosis.
Right. That is the specific disease that produces dangerous lipid-stuffed plaques in the inner lining of the artery. Those plaques are the ones that rupture and instantly stop blood flow to the heart or brain.
Okay, let's unpack this, because we all grew up with this textbook image from the 1960s and 70s, right? You eat too many cheeseburgers, the fat floats through your bloodstream, and it just passively sticks in the walls, layer by layer, until the pipe is totally choked off. Is it basically just pouring bacon grease down a sink?
I get why people think that. That framing dominated medical education for a century because visually it makes intuitive sense.
Right, it seems logical.
Yeah, when early pathologists opened up a blocked artery post-mortem, they saw a lump of fat and a blood clot. So the logical deduction was just a slow mechanical buildup.
But that's not what's happening.
No. In the 1970s, a pathologist named Russell Ross introduced the response to injury hypothesis, and that forced the medical field to realize we were looking at it totally backwards.
Backwards how?
Atherosclerosis isn't a passive buildup of fat. It is an active, smoldering immune battlefield. It's a chronic, maladaptive immune response.
Okay, so the artery wall is actively mounting an immune response.
Exactly. It treats trapped lipid particles like they're a bacterial infection. It sends in white blood cells to clean up the mess, but because the lipids just keep arriving, the infection never resolves.
So the immune cells just keep fighting a war they can never win.
Basically, yeah. We had to move from viewing the artery as a dumb pipe to recognizing it as a complex living organ that actively responds to its environment, often to our detriment.
Wow. Okay, so if this is an active war zone, we need to look at how the battle actually starts in our arteries.
Let's do it.
The sources focus heavily on the endothelium, right? that single microscopic layer of cells lining the inside of every artery. I was reading this and thinking of it like the non-stick coating on a frying pan,
That's a perfect analogy, actually.
right, where blood is supposed to just glide right past.
Yeah, in a healthy state, that endothelial lining is a selective, highly functional barrier. It regulates local blood pressure by releasing nitric oxide, and it actively prevents cells and proteins in the blood from just adhering to the vessel wall.
So it keeps the non-stick pan slick.
Exactly.
But then we expose that lining to chronic high blood pressure, or the chemicals in cigarette smoke, or high blood sugar from diabetes.
Or elevated levels of LDL cholesterol, yeah.
Right. And that physically or chemically damages that nonstick lining. It becomes leaky. But what really caught my attention in the research is that it doesn't just passively fail. The damaged pan actively sprouts cellular Velcro.
It does. The injured endothelium starts expressing specific adhesion molecules. These are proteins with names like VCAM1 and ICAM1.
VCAM and ICAM?
Yeah, and they literally stick out into the rushing bloodstream specifically to snag passing white blood cells. The artery is signaling that it's injured and actively calling for immune reinforcements to enter the tissue.
It's intentionally pulling the immune system into the wall. That's crazy.
It really is.
And while the endothelium is leaky and inflamed like this, the LDL cholesterol slips through. It moves out of the bloodstream and gets trapped in the inner layer of the artery wall, which is called the intima.
Right. And once it's trapped in the intima, the LDL is cut off from the antioxidants that are normally present in the circulating blood. So it undergoes oxidation.
It gets oxidized.
Yeah, and that chemical change is the biological tripwire. The immune system suddenly recognizes this oxidized LDL not as a normal lipid transporter, but as foreign toxic material.
So the alarm bells go off.
Major alarm bells.
If this oxidized LDL is just sitting in the artery wall, setting off these immune alarms, how does the body actually try to disarm it? Like, it can't just leave it there, right?
No, it sends in the troops. White blood cells called monocytes heed the call from those Velcro-like adhesion molecules. They squeeze through the endothelial lining into the artery wall, and they transform into macrophages. Yeah. They act as the body's cellular garbage trucks. Their primary evolutionary directive is to engulf the oxidized LDL and clear the tissue to, resolve the inflammation.
Which sounds like exactly what you would want your immune system to do, right? Clear the garbage.
It would be, except for a massive biological design flaw.
Ah.
Yeah. The specific receptors these macrophages use to recognize and eat the oxidized LDL, they're called scavenger receptors, they lack negative feedback regulation. They literally do not have an off switch.
Wait, so they don't know when they're full?
Exactly. They just keep eating the trapped lipids until they totally engorge themselves.
Wow. And the microscopic images in the sources show these bloated cells looking incredibly bubbly, which is why they are called foam cells.
Yeah, foam cells. And clusters of these bloated, dying foam cells create the very first visible sign of the disease on the artery wall, which is a fatty streak.
A fatty streak.
Right. It's essentially a microscopic graveyard of immune cells that ate themselves to death trying to clear the oxidized LDL.
That is incredibly grim. So that dead cellular debris just starts to pile up inside the wall.
It does.
The etymology here perfectly captures the physical reality of this. In 1904, the German pathologist Felix Marchand coined the term atherosclerosis. He fused two Greek words.
Atherosclerosis.
Right. Ather, meaning gruel or porridge, and sclerosis, meaning hardening. So gruel hardening.
He was describing the exact anatomy of the developing plaque, because the center becomes the soft, yellowish, necrotic core, the gruel. It's a highly toxic mix of dead foam cells, cholesterol crystals, and inflammatory enzymes.
It's a toxic soup. So to try and contain that growing pile of gruel, the body attempts to wall it off from the bloodstream, right?
Yes. Smooth muscle cells migrate over the top of the lipid pool and build a tough, collagen-rich, fibrous cap.
It's like the biological equivalent of pouring a concrete dome over a radioactive waste dump.
That is exactly what it is. And over years, this whole structure can calcify, harden, and grow inward, which narrows the channel where the blood flows.
And this brings us to a part of the source material that completely flips the script on how we assess heart attack risk. Because if this plaque is walled off under a thick cap, slowly growing and narrowing the artery, the intuitive leap is that the biggest plaques, the ones choking off like 90% of the blood flow, are the ones causing sudden heart attacks. They just grow until they seal the pipe.
What's fascinating here is that the clinical reality operates on a totally different logic. The risk of a heart attack depends primarily on the plaque's composition, not its sheer size.
So a 90% blockage isn't necessarily the ticking time bomb we think it is?
Not always, no. Picture a massive plaque blocking 80% or 90% of an artery. Because it has grown slowly over decades, the body has extensively fortified it.
Fortified it how?
It has a very thick, heavily calcified, stable, fibrous cap. Now, it will absolutely cause symptoms like you'll get chest pain when you climb a flight of stairs because blood flow is mechanically restricted.
Sure, because the pipe is mostly blocked.
Right, but it is physically very stable. The cap is tough.
So it restricts flow, but it doesn't suddenly explode.
Exactly. Now contrast that with a much smaller plaque. Say it only blocks 30% of the artery.
Okay, 30%. You could pass a treadmill stress test and feel completely fine with that because there is plenty of room for blood to flow around it.
Exactly. But that 30% plaque might have a massive soft lipid core of that toxic gruel and a dangerously thin fibrous cap.
A thin cap over a big toxic pool.
Right. And the macrophages inside the core are actively releasing enzymes called matrix metalloproteinases.
Metalloproteinases, got it.
Yeah, and these enzymes eat away at the collagen in the cap, trying to dissolve the tissue from the inside out.
So you basically have a highly inflamed, structurally weak blister sitting in a high-pressure blood vessel.
Precisely. And if that thin cap tears, it's not a slow narrowing that kills you.
What happens when it tears?
If the cap ruptures, the flowing blood is instantaneously exposed to the highly thrombogenic material inside the necrotic core.
And thrombogenic basically means it triggers aggressive blood clotting. Right.
Yes. The body thinks a major blood vessel has been breached, and you're bleeding internally, so it initiates a massive coagulation cascade in seconds to minutes.
Wow. And the resulting blood clot is what suddenly and completely blocks the artery.
That is the heart attack.
That is just wow. We spent all this time looking for severe blockages on imaging, assuming size dictates danger, while completely missing the biological stability of the plaque.
Exactly. A mild, highly inflamed plaque rupturing is what takes down a marathon runner who had 0 prior symptoms. We spent decades focusing on how much the vessel was narrowed, ignoring the fact that it's the inflammatory state of the plaque that actually dictates who lives and who dies.
So knowing that even small, non-obstructive plaques can be so deadly, we have to look at the timeline of all this. The general assumption is that, you live a modern lifestyle for 50 years, and in your 60s, your arteries finally start failing from the accumulated fast food.
Right, that's the myth. But the disease has a multi-decade silent phase that begins much, much earlier than most people are comfortable acknowledging.
The autopsy study from the Korean War in 1953 really highlights this. I found this part so surprising. Pathologists examined 300 American soldiers killed in action, and the average age of these men was 22.
Just 22 years old.
Yeah, and the medical establishment expected to find pristine arteries, but instead they found roughly 77% of these 22-year-olds already had gross, visible coronary atherosclerosis.
Which was shocking at the time. But subsequent research confirmed it wasn't just an anomaly related to wartime stress or something.
Right, like the PDA study in the 80s and 90s.
Yes, the PDA study examined young Americans aged 15 to 34 who died in routine accidents. And they found fatty streaks, those microscopic graveyards of foam cells, in nearly all the teenagers studied.
Nearly all of them.
Teenagers? Yeah. And the severity directly tracked with adolescent risk factors like elevated LDL cholesterol and smoking.
So the immune war in the arteries actually begins in high school.
It does.
The immediate instinct is to blame modern diets, right? Processed food, sedentary lifestyles, refined sugars. Here's where it gets really interesting. In 2011, researchers conducted the HORACE study, which challenges that entire premise.
Oh, the HORACE study is fascinating. They performed whole-body CT scans on mummies from 4 distinct ancient cultures.
Mummies in a CT scanner.
Yeah. We are talking ancient Egyptians, ancient Peruvians, ancestral Pueblones from the American Southwest, and the Unangan people from the Aleutian Islands.
That spans like 4,000 years of human history, covering wildly different diets and environments. You've got agricultural societies, coastal foragers, and pure hunter-gatherer populations who obviously never touched a refined carb or a processed oil.
Exactly. The CT scans looked for the dense calcium deposits that are left behind in the arterial beds after soft tissue decays.
And what did they find?
They found probable or definite atherosclerosis in over a third of the mummies studied, across all 4 ancient populations.
Over a third. We've always framed atherosclerosis as a penalty for industrialized living. Finding it in ancient hunter-gatherers suggests there is a fundamental inflammatory aging component to this.
Yeah, it implies this vascular response to injury has just always been a part of the human condition. It forces us to consider that the biological reality of having a highly reactive immune system and moving lipids through pressurized tubes might inherently lead to this wear and tear over a lifespan, regardless of the era you live in.
So if humanity has been carrying this vascular vulnerability for 4,000 years, the medical history of how you tried to treat it is basically a century of fierce debate. In the 1850s, the medical field was split between two legendary pathologists trying to figure out what initiated the disease.
Right, you had Karl von Rokitansky in Austria.
And he believed plaques started as small blood clots on the vessel wall, right? That slowly turned into fibrous, fatty tissue over time.
Yeah, the incrustation theory. But then in 1856, the German pathologist Rudolf Virchow argued Rokitansky was wrong.
Virchow theorized it started with an injury to the artery lining, followed by localized inflammation, driving the fatty buildup from the very beginning. Looking back at the sources, you can see why they were locked in this debate. I mean, they were using 19th century microscopes to look at dead tissue during autopsies.
Exactly. It was the ultimate chicken or egg problem. When you look at an advanced ruptured plaque post-mortem, you see a massive clot and severe inflammation.
Right, they're both there.
Yeah, and because the disease takes decades to develop, it was nearly impossible for them to tell which one actually initiated the process.
So that debate, is it driven by lipids and blood clots, or is it driven by injury and inflammation? That raged for 150 years.
A long time.
And for a long time, the lipid side of the debate dominated. The sources point to Nikolai Enichkow's 1913 experiment in St. Petersburg as a major turning point for that.
Oh, the rabbit study. He fed pure cholesterol dissolved in sunflower oil to rabbits. And because rabbits are herbivores that do not naturally consume cholesterol, their biology couldn't process it.
So what happened to them?
Within weeks, they developed aortic plaques that were structurally identical to human atherosclerosis.
Wow. So it proved that a chemical you ingest could physically cause the disease.
Yes.
And then, jumping ahead to 1985, Michael Brown and Joseph Goldstein won the Nobel Prize for decoding familial hypercholesterolemia. They found that some people are born with defective LDL receptors.
Right. Their livers simply cannot clear cholesterol from the blood.
And those individuals, even young, active athletes with perfect diets, were dying of severe heart attacks in their 20s and 30s. So the genetic lipid burden alone was enough to overwhelm the arteries and trigger that entire immune cascade.
And that discovery was monumental because it directly led to the development of statins, which boost those receptors to clear cholesterol from the blood. For decades after that, cardiology focused relentlessly on just driving down LDL.
So what does this all mean for Virchow's inflammation theory? Did lipids win the debate? Was Virchow just a historical footnote?
This raises an important question, actually, because skeptics in the cardiology community kept pointing out a glaring issue with the purely lipid-focused approach.
Which was what?
Patients on heavy statin therapy with perfectly controlled cholesterol were still having recurrent heart attacks.
Wait, really? Even with low cholesterol?
Yes, but those specific patients often showed elevated inflammatory markers in their blood, like C-reactive protein.
Ah, so the microscopic fire was still burning in the artery wall, even without massive amounts of fuel.
Exactly. Which brings us to a massive breakthrough in 2017 with the CANTOS trial, led by cardiologist Paul Ritker.
Okay, wait, let me make sure I have this right. They took thousands of patients who had already suffered a heart attack and still had high inflammatory markers.
Right.
But instead of giving them another drug to lower cholesterol, they gave them an antibody called canakinumab.
A drug that does absolutely nothing to lipid levels. It is purely an anti-inflammatory agent.
How does it work?
It works by blocking a very specific signaling pathway in the innate immune system called interleukin-1 beta.
You're telling me they targeted the immune system, leaving the cholesterol completely alone, and it stopped second heart attacks just by calming the inflammation.
It significantly reduced recurrent cardiovascular events, yes. It was the first large-scale definitive proof that targeting inflammation alone, independent of lipids, could actually alter the course of the disease.
That is incredible. So more than 160 years later, Virchow's 1856 inflammation theory was finally vindicated. The plaque isn't just a passive pile of fat, it's a living inflammatory lesion.
Exactly. Calming the immune system stabilizes that fibrous cap, preventing the sudden rupture.
It requires us to treat both the lipids that fuel the fire and the inflammation that sparks the rupture. Both sides of the historical debate were ultimately right.
They were, and that completely rewrites the playbook.
It really does. So to seamlessly recap this journey for you, atherosclerosis is absolutely not a clogged pipe under the sink. It is a chronic, smoldering immune war in the walls of your arteries.
A war that begins much earlier than we assume.
Yeah, often in adolescence, driven by the deadly intersection of trapped, oxidized LDL and those overzealous phone cells that just don't know when to quit.
And most crucially, it kills via the sudden, violent rupture of inflamed, thin-capped plaques, regardless of how much they actually narrow the artery.
It is a dynamic, living disease. But understanding the mechanism gives us the power to actually intervene before the cap tears.
Right, we have the tools now.
As we wrap up this deep dive, consider this final thought based on the evidence we've covered today. If fatty streaks are already forming in our arteries by high school, and ancient hunter-gatherers developed plaques 4,000 years ago without ever touching a modern processed diet, perhaps we need to stop thinking of atherosclerosis as an illness you catch in your 60s due to bad habits.
The evidence strongly suggests we must view it as an inevitable, lifelong human process. It's just the biological wear and tear of having a lipid-based energy system and a highly reactive immune system.
And if it's an inevitable process, well, it's something we have to actively and consciously manage from the very beginning of our adult lives, rather than just waiting for symptoms to appear. So next time you picture your heart health, ditch the plumbing tools. You're not unclogging a drain.
No, you're managing a lifelong negotiation with your own immune system.
Exactly. Thanks for joining us on this deep dive. We'll catch you next time.